In our final lecture, in the pulmonary section of Step 2 High Yield, we're going to discuss pulmonary hypertension, obstructive sleep apnea, and ARDS. Let us begin with a discussion of pulmonary hypertension. In the healthy lung, the pulmonary circulation is typically extremely low pressure. Systolics are normally 25 millimeters of mercury, diastolics of 8, and a mean of about 15. Values higher than this signify the presence of pulmonary hypertension. Pulmonary hypertension is defined as either primary or secondary. Primary pulmonary hypertension is a disease characterized by idiopathic dysfunction of the pulmonary arteries without some other underlying cause. Whereas secondary causes of pulmonary hypertension include left-sided heart failure, which is by far the most common culprit, intracardiac left-to-right shunting, hypoxic vasoconstriction from chronic lung disease, for example, COPD, or thromboembolic disease. On Step 2, you should remember that chronic hypoxemia from any cause can lead to pulmonary hypertension. That's because, again, the normal response in the lung to hypoxia is to cause vasoconstriction. Vasoconstriction is going to cause pulmonary hypertension. Unfortunately, the presence of pulmonary hypertension actually results in more hypoxemia, mostly because once the vessels are thickened, it's even harder for oxygen to travel from the alveolus across the interalveolar septae through the blood vessels and into the blood. The presentation of a patient with pulmonary hypertension typically consists of dyspnea and fatigue. The patient will complain of exertional syncope, and anytime you think of that, you want to think of obstructive causes of this. The obstruction may be at the level of the left ventricular outflow tract in a disease such as hypertrophic obstructive cardiomyopathy. However, the obstruction may be in the lungs itself. This is pulmonary hypertension. The patient tries to augment their cardiac output during exertion. Because of the high pressures in the lung, their right ventricle is not able to pump enough blood to the left side of the heart, and exertional syncope can occur. Patients will also have exertional chest pain. This is angina as a result of ischemia to a dilated and dysfunctional right ventricle, which is pumping against extremely high afterload. On exam, you'll often hear splitting of the S2 with a loud P2 component. Tricuspid and pulmonary valve insufficiency may also be present. These patients will also develop signs of right-sided heart failure, including edema and elevated JVP. Remember, it's impossible to know that pulmonary hypertension is causing their dyspnea without doing some further testing. Some diagnostic tests might include chest X-ray and chest CT. These are the best initial tests. They will show dilation of the proximal pulmonary arteries with narrowing or pruning of the distal vessels. Here's an example of a chest X-ray of a patient with severe pulmonary hypertension. You see very large proximal pulmonary arteries bilaterally. The ultimate diagnostic test, and the most accurate, will be a right heart or Swan-Ganz catheter. And it's the most precise method to measure the pressures within the different chambers of the heart. This is a picture of how a Swan-Ganz catheter is inserted. It usually goes in through the internal jugular vein and can be threaded down through the SVC into the RA, RV, and all the way into the pulmonary artery. A small balloon at the tip of the pulmonary artery catheter can be inflated and wedged into one of the distal pulmonary arteries. This is a way to measure the pulmonary capillary wedge pressure, which is an estimate of left atrial pressure and hence the left ventricular end diastolic pressure. Other diagnostic testing might include an EKG, which can show signs of right axis deviation, right atrial and right ventricular hypertrophy. Echocardiography is often remarkable for an enlarged RA and RV, and Doppler can be used to estimate the pulmonary artery pressures. VQ scanning, or ventilation perfusion scanning, is sometimes used as well. This is very helpful in identifying chronic pulmonary embolism as a potential cause of pulmonary hypertension. A CBC, will sometimes show polycythemia if the patient has severe chronic hypoxia. Regarding the management of patients with pulmonary hypertension, if there is an underlying cause, correcting it is going to be the first step. Idiopathic disease, on the other hand, is often treated with inhaled or intravenous prostacyclin analogs. These act as pulmonary arterial vasodilators. They're going to improve blood flow through the lungs and are going to decrease the afterload on the right ventricle. Epoprostenol, treprostinol, iloprost, and beroprost are commonly tested examples. Also, we sometimes use endothelin antagonists, such as bosentan. Other drugs used include phosphodiesterase inhibitors, such as sildenafil, or calcium channel blockers. These are only used if they're demonstrated to be responsive to them during right heart catheterization. In many patients, calcium channel blockers are not at all helpful. Oxygen has also been shown to slow the progression of pulmonary hypertension in severe cases, particularly with patients with COPD. Remember, the only curative way to treat idiopathic pulmonary hypertension is through lung transplantation. At this point, let's shift gears and discuss obstructive sleep apnea, which is actually a quite common cause of pulmonary hypertension. Obstructive sleep apnea is defined as cessation of airflow due to upper airway obstruction during sleep. The most commonly identified cause is obesity. As you can see, if the patient has a lot of upper airway obstruction, air is unable to get through down into the trachea while the patient is in a supine position. The most common presentation of obstructive sleep apnea is a patient coming in with daytime somnolence as well as a history of loud snoring. Other symptoms include headache, impaired memory and judgment, depression, hypertension, and erectile dysfunction. Remember, the headache in this situation is secondary to early morning hypercarbia after a night of frequent obstructions. The risk factors for developing obstructive sleep apnea are actually quite intuitive. These include male gender, obesity, a large uvula or large tongue, and retrognathia, also defined as a recession of the mandible or a very small chin. All of these are risk factors that increase the chance of developing obstructive sleep apnea. Other presentations of the disease can include arrhythmias and erythrocytosis if the patient has chronic nocturnal hypoxia. If the chronic nocturnal hypoxia is particularly severe and untreated, as we said before, chronic hypoxia is going to lead to hypoxic vasoconstriction in the lung, and these patients can develop pulmonary hypertension and RV failure. The most accurate test to diagnose OSA will be polysomnography, or a sleep study. You're going to see multiple episodes of apnea during the night when the patient actually stops breathing. For patients with obstructive sleep apnea, they can be treated by modifying their risk factors. For the obese patient, weight loss is key. In addition, patients should avoid alcohol, as alcohol can worsen the number of apneas a patient has at night. The mainstay of therapy, however, is nasal continuous positive airway pressure, or CPAP. As the name implies, this tubing that's connected to the patient's oropharynx or nose is going to apply positive airway pressure throughout the night. This helps to keep the patient's airway patent and is going to decrease the number of apneas the patient experiences during the night. In the worst case scenarios, some patients actually require surgical widening of the airway, also known as uvulopharyngoplasty. Just like alcohol, other sedatives should be avoided. To conclude our lecture, let's discuss acute respiratory distress syndrome. Acute respiratory distress syndrome, also known as ARDS, is an acute respiratory failure that can either occur from an overwhelming lung injury or from some systemic disease that actually secondarily affects the lung. It's characterized by the following: severe hypoxia, poor lung compliance, extremely stiff lungs. And the patient will have non-cardiogenic pulmonary edema. ARDS is essentially caused by endothelial injury at the level of the alveolus. What's going on is that the cells become so leaky that the alveoli will fill up with fluid. Again, the key to defining ARDS is that this pulmonary edema is non-cardiogenic in nature. While our understanding of ARDS's pathophysiology has improved in recent years, it is still poorly defined. It's idiopathic in nature, and there are a large number of illnesses and injuries that are associated with this alveolar epithelial cell and capillary endothelial cell damage. The most common illnesses and injuries that cause ARDS include the following: sepsis or aspiration, any lung contusion or blunt trauma, near drowning, and patients who develop severe burns or a severe acute pancreatitis. This is only a short list of many causes, but the ones you should be most familiar with for step 2. The chest x-ray in ARDS is seldom subtle. You're going to see dense bilateral infiltrates which quickly become confluent and cause complete bilateral whiteout of the lungs on chest x-ray. In fact, the pulmonary edema is so severe that you often see air bronchograms on both chest x-ray and chest CT. These indicate areas where the alveolar infiltrates are so dense that the airways running through them actually appear as hyperlucencies on the chest x-ray. Here's an example of the bilateral whiteout seen on an ARDS chest x-ray. We have dense, puffy, cotton-appearing alveolar infiltrates on both sides of the lung. Here's a chest CT very clearly demonstrating air bronchograms. These are signs again of dense consolidation in the lung airspace. ARDS actually has criteria that must be met in order to define it. This includes a ratio of the PaO2 in arterial blood divided by the inspired fraction of oxygen. If that ratio is less than 200, they might fit criteria for ARDS. Remember, the FiO2 is expressed as a decimal. For example, on room air, which has 21% oxygen, we call this 0.21 when we plug it into this equation. If the PaO2 is 105 on room air, for example, and therefore the fraction of oxygen is 0.21, then the ratio would be 500, and that patient cannot be said to have ARDS. If, for example, you have a patient with a PaO2 of 70, while they're inspiring 50% oxygen, then the ratio becomes 70 divided by 0.5, or 140. This patient would fit criteria for ARDS. ARDS, importantly, is associated with normal findings on right heart catheterization. In addition to having the PaO2 divided by FiO2 ratio less than 200, in order to have ARDS, you must also have a normal capillary wedge pressure. It must be less than 18 in order to call it non-cardiogenic. Patients with ARDS almost always require intubation and mechanical ventilation. The best way to treat these patients is through low tidal volume mechanical ventilation. This gives the lungs the best chance to recover. As a rule of thumb, we use 6 milliliters per kilogram of tidal volume. Steroids, however, are not clearly beneficial in most cases. They can help in late-stage disease, in which pulmonary fibrosis can often ensue. However, again, the mainstay of therapy is going to be using low tidal volumes to minimize damage from overstretching the alveoli, which can worsen the ARDS and respiratory failure. In addition, patients with ARDS will often develop severe hypoxia and require very high levels of FiO2 in order to maintain their oxygenation. As you should remember, levels of FiO2 greater than 50% for any long period of time are going to be toxic to the lungs. Therefore, to decrease the use of high FiO2s, we can improve the patient's oxygenation through a different means, and that's through the use of positive end expiratory pressure, or PEEP. This works in a very similar manner to CPAP, which we described earlier in the lecture. Positive end expiratory pressure helps to keep the alveoli stented open throughout the respiratory cycle, hence improving oxygenation. One other way to help the patient with ARDS is to try to maintain a plateau pressure on the ventilator less than 30 centimeters of water. We can measure the plateau pressure using the monitor on the ventilator, and a plateau pressure is often indicative of the underlying lung compliance. Keeping it less than 30 ensures that you're not causing too much barotrauma to the lungs. Remember, no treatment has been proven to reverse ARDS. The mainstay of therapy is supportive, and you need to treat the underlying cause. This concludes our lecture.